I'm going to tell you a little bit about the O'Neill Institute, as well as a little bit more about the other work we do here, introduce the panelists, and talk a little bit about the reason for this convening today. So if I can get the slides to work. Okay, sorry, we'll just play music until we get the slides up. But first, perhaps I wanted to, and I have this nice slide, but I will introduce Rick Ostrom first, who's going to talk about C4 recovery and the work that we do.
Thanks everybody for attending. Joe, a special thanks to you. This is a real privilege to have you. Thanks to Georgetown, Regina, your great team. And I'm assuming Shelley is watching, so hello out there. I hope everything is going well with 2 instead of 1. That's a little scary. C4 is a 501c3 that's been in the addiction behavioral health space for a very long time. I'm officially old. We started in 1986. And we've been making trouble both in America and around the world since then. And I'm particularly glad to do this today because we're at a very interesting juncture in kind of addiction policy, et cetera, in America. And the appearance of Chow is really relevant at this time. And what I'm hoping is going to happen here today is what's not happening outside of here, which is any kind of moderate thinking discussion of the policy changes that are underway. We're in the middle of an express track to areas that probably aren't going to yield everything we want them to yield. And so I'm hoping today that instead of propaganda, maneuvering, and manipulation, we're going to listen to people with lived experience and understand what worked, what didn't work, what we should do better, and what we shouldn't do at all. I think that it's really good news that we're unwinding the war on people, which was all the war on drugs ever really was. But I also think that in a time of great change, there is the possibility of moving too fast, as us Americans are wont to do, and breaking a lot of things on the way. So I hope the discussion today will avoid some of those mistakes and leave all of us with a better understanding of both the potentials and the challenges that lie ahead of us. Thanks again.
Thank you, Rick, and thanks so much for your support for this program. We're at the O'Neill Institute at Georgetown University Law Center. The O'Neill Institute is an organization that operates at the intersection of public health and law to improve health outcomes for individuals, both in the United States and internationally. This is C4 recovery. So the Addiction and Public Policy Initiative is part of the O'Neill Institute. And we work on a number of issues, but really everything we do is to advance evidence-based practices to address substance use disorder in the United States by building recovery capacity, by informing the addiction policy workforce, and also I teach in and direct the Masters of Science in Addiction Policy and Practice program. This is a 1-year master's program that's intended to build the addiction policy workforce. And I'm really pleased that several of our new graduates and current students are here today. Several of our students just graduated and are entering the addiction policy workforce, and then another cohort just started a couple weeks ago. We also have many of our professors here today. So I want to, I've spent quite a bit of time at working at the federal level as well as on at the city of Seattle, working on the issue of addiction, substance use disorder, and considerably more years addressing issues at the nexus of public health and public safety. So in that time, I've recognized that many issues, like overdose deaths, we refer to them as crises. Now, I don't believe that we should call them crises, because a crisis implies there's a beginning and a middle and an end. And I think we need to look at this issue, and you'll hear about this today with Portugal's approach. This issue is something that we know there will be individuals with substance use disorder in our country. We know that their prevention, treatment, harm reduction, recovery programs need to continue. And so calling it a crisis implies that there's going to be a way that we can just say goodbye to this and end it. And that's really not how it works. So issues evolve over time. The science evolves, our approaches evolve. We learn more about substance use disorder and how to treat addiction, as well as drug uses change over time as well. So this morning, the Office of National Drug Control Policy and the Biden administration just released their plan to deal with xylazine. I mean, I bet you 10 years ago, not one of us, unless you worked on a farm, could tell you what xylazine is. Well, now a lot of people are talking about xylazine in the drug supply and the harms it's causing, very real harms it's causing to individuals in this country. So flexibility as we look at emerging trends is very important, but so too is sustained investments. And that's one of the things we're going to talk about today. Sustained financial investments over time, where we're not looking at short-term grants. When we look at diseases of addiction or issues of addiction, prevention, treatment, those things, if they're not crises, they can't be solved with one-time grants. So that's why we're here today, to talk about the lessons and lessons that we can learn and what can we take away from Portugal's approach to drug policy. So as Dr. Goulão has said, this approach is not simply decriminalization. And it can't be a cut and paste drug policy. Each country's social circumstances have to be taken into account. And later this week, we'll be releasing this quick take, which will include some of the lessons learned from Portugal's approach. And these are some of the lessons that we think can be taken away. First of all, substance use disorder is a health issue, not a criminal issue. Make substantial and consistent financial investments in public health services. Allocate robust financial investments to data collection and data reporting. And lastly, this is an all-in approach. We can't leave one group of people or one group of policymakers out of this solution. So collaborate across different disciplines, and that includes public health and public safety, as well as people with lived or living experience. So with that overview, I want to turn it over to our panel. And one of our main missions in the Master of Science in Addiction Policy and Practice is to train the addiction policy workforce in the science and evidence of addiction, while also making sure they are grounded in compassion. And I can't think of 4 people more emblematic of that approach. They are driven by science and evidence. They are rooted in compassion. And that's the solution to our issues. So moderating the event is Michael Botticelli. Michael was the director of National Drug Control Policy in the Obama administration, the second part of the Obama administration. He is a stalwart advocate for a public health approach to addiction. And Michael was also the first director of the Office of National Drug Control Policy to be in recovery. Then, of course, we have Dr. Goulão. Dr. Goulão is a physician and the National Drug Coordinator for Portugal. He was also one of the architects of Portugal's drug policy plan. We have Assistant Secretary Miriam Delphin-Rittman with the Substance Abuse and Mental Health Services Administration at the Department of Health and Human Services. She served in this position since 2021, is a psychologist who served as commissioner of the Connecticut Department of Mental Health and Addiction Services. And then last but not least, of course, we have Dr. Brandon Del Pozo. Dr. Del Pozo is an assistant professor at Brown University, conducts NIH research at the intersection of public health, public safety, and justice, where he focuses on substance use, the overdose crisis, and violence. He also served as police chief in Vermont and with the New York Police Department. So with that, I'm going to turn it over to the panel. There will be time for questions. Each of you has on your chair question. You can fill it out. There's a nice little pen there too. Fill out the questions. And then also folks online can also ask questions through the chat function. So with that, Michael.
Great, thank you, got it. Thank you, Regina, for that. And good morning, everybody. It's really a pleasure to be here. It's always a pleasure to be in Washington as a non-government official, which I guess is part of the conversation today. So I want to start with Dr. Goulão here, because I think those of us, and that probably includes everybody in this room, everybody who's watching, have worked in and around kind of political environments and have tried to move drug policy in a political environment. So I wonder if you could give us some kind of context and history here in terms of what was the social and political environment like in Portugal that even allowed for this kind of debate and this kind of conversation.
Good start, I think so. Hello, everybody. It's a pleasure being here with you. I want to thank the invitation, and it's really a pleasure having this opportunity to share some views with you, my dear colleagues of this panel, and everybody here and watching virtually. Well, what was the social environment? I would not like to spend too much time in explaining this, but in fact we had quite specific historical conditions in Portugal to the beginning of drug-related problems in our society. In fact, those conditions, those problems exploded after our democratic revolution and the decolonization process. As you know, we had a colonial empire in Angola, Mozambique, and so on. And in the last years of the regime, authoritarian regime of Salazar, Caetano, we were dealing with a colonial war in those ancient territories. Before our democratic revolution, the Decriminalization revolution in '74, I would say that drugs were not an issue in our society. But after that, with a sudden opening to the world, with the return of soldiers and settlers from the ancient colonies, suddenly we had an explosion in experimentation of drugs. And what, in my view, it's very important for that period, is that explosion, that experimentation happened cross-cutting completely our society. It was not something that happened only or mostly among marginalized communities, poor neighborhoods, racial or other minorities, but it happens through all social groups. Of course, it attained mostly the poorest, but medium class, upper class, political class, everybody was attained by the drugs phenomenon. And in just a matter of a decade, in 10 years, it was almost impossible to find a Portuguese family that had no problems related to drugs. So it became a problem for everybody, not only for some parts of the society. I think this is probably the most important part of it, because we can easily imagine when heroin became the most popular substance in our society, or at least the substance with the biggest impact in our society, that it was not a problem that people could say, no, it's their problem. No, it was the problem for everybody, and people tended to be a humane approach for that, even if the environment was quite tough and inspired in the war on drugs.
So you have a situation where, because of the ubiquitous nature of the problem, that influenced the political debate in terms of a much more humane approach that precipitated this discussion about movement toward decriminalization.
Yes, but prior to that, what we saw was the increasing importance of the development of health and social responses to people affected by drugs, rather than the criminal and the prosecution approach. People tended to think, well, my son is not a criminal. My son is someone in need of help, and I would say 2 decades prior to decriminalization, the social attitude was mostly based in this idea. We are dealing with a health problem rather than a criminal.
And was that attitude reflected across the political spectrum in Portugal? Did most people who entered this debate and discussion kind of carry that view that Portugal should have a much more humane approach that included decriminalization?
Not at the time, but in fact, what the development of the responses to the drugs problems were mostly installed under the Ministry of Health and Social Affairs, rather than in justice. And this happened with different governments coming from different parts. So it was a sustained attitude, sustained framework for the development of the responses.
Regina laid out kind of 4 lessons learned from Portugal. But I want to ask you kind of what do you think the biggest kind of misconceptions or misrepresentation of Portugal's policy is in the rest of this? This is your opportunity to kind of correct the record, if you will, in terms of what you think kind of are the most significant kind of misrepresentations in terms of Portugal's policy.
As you know, there's a lot of interest concerning the Portuguese approach to drugs problems, but it is, in my view, it's too much focused on decriminalization. Okay? Because in fact, I believe that what is important is the development of health responses, social responses to people who use drugs. And decriminalization was a little bit the final step to turn everything much more coherent with that idea. Okay, we are dealing with a chronic relapsing disease. We do not criminalize other diseases, even if some of them depend on our habits, of our attitudes. I think thinking about diabetes or other kind of. So we do not criminalize people who suffer from this kind of diseases. So when we decided in the context of the first national strategy for drugs to include decriminalization, it's important to say that first of all, we had a framework that was imposed by the government when we were invited to build that strategy. We were said, okay, you may propose whatever you want, but you must fit within the spirit of the treaties of the United Nations. That, as you know, impose a prohibitionist paradigm. Nowhere in the treaties it is said that the drug use should be criminalized, but it is said that it should be prohibited and punished. I think we have different systems here in the States or in Portugal, because we have some kind of felonies that are that are punished under the administrative law. I'm thinking about the use or not use of the safety belt when you drive. If you do not wear your safety belt, the police officer still stops you, may apply you a fine in place. In theory, may impose that you attend a training course for drivers, but you do not get a criminal record. You do not end up in prison by the mere not use of the safety belt. What we thought it would be a solution is exactly the same. Okay, if someone is using, first of all, using drugs is still prohibited in Portugal. But if you are intercepted by the police authority using drugs or in possession of small amounts of drugs for personal use, you, instead of going to jail, going to court, having a trial in the criminal system, you are just sent to be presented to a panel, an administrative panel under the Ministry of Health, where you are going to interact with health personnel and where the kind of needs that you may have is going to be evaluated. Are you an addicted person in need of treatment? Do you need, okay? The panel will help you, if you so wish, will help you to find a way, to find a treatment response or a response on the context of harm reduction, such as a low threshold methadone program or something like that. But if you are not a problematic user, if you are not addicted, and the vast majority of people who are present to those commissions are not, in fact, addicted people, this acts as an indicated prevention tool. Okay, I have no, someone tells you, oh, I have no problems related to drugs. I smoke a joint on weekends with my friends, but my parents are divorcing. My father just lost his job. I am facing some problems, some psychological disturbance, some eating disorder, some kind of problem, something that along with drug use may lead you to a more problematic use later on. So the aim is to interrupt that career and to address you to the indicated response in society, not in a facility for the treatment of drug addiction. Okay? And this is quite effective. So I would say this is one of the main aspects of course, we need to have those responses in place, easily available, for free, anonymous if possible, so in order to respect the privacy of people.
I want to address something that is probably on top of mind for everyone here and give you a chance to respond. I think many of us saw the Washington Post article that had some criticism or some kind of upticks in drug use and overdose that were prompting some people to kind of rethink the decriminalization and the current policy. And I want to give you an opportunity to kind of respond to that and get your reaction to. So this is his letter to the editor that didn't.
Thank you. Thank you, Mark. Of course, in these 20 something years, I'm used to have some criticism. Not everything we have applauses, and not everything that is published is exactly corresponds exactly to what we think about it. It is true that we are having some difficulties nowadays in supplying timely treatment without waiting lists, for instance. We have a visibility of disorganized users on the streets in Lisbon and Porto, mostly in the big cities. And we are concerned about it. But in my view, it has much more to see with some difficulties. First, resulting from the pandemic crisis, and nowadays with the increased difficulties that people are facing, we have more people on the street. And I would say that at a given moment, our political responsibles were convinced that drugs problems in Portugal were solved. Okay? So there was a stagnation or even a decrease. It's not exactly the same decrease that is said in the Washington Post article, but it's not his fault. It's probably we explained the wrong. There was a misunderstanding about the cuts, but in fact we are not investing as much as we should. As Regina said in her introduction, one of the main questions is to keep the investment to sustain. If we are dealing with a chronic relapsing disease, we must keep the investment adequate to this situation. We cannot just go, oh, okay, it's a bright day today, no problems in the horizon. Okay, let's cut the responses. When increased difficulties, social or difficulties appear, we cannot but wait that problems will increase again. That's what's happening. Hopefully, we had differences in the organization that we have installed in the Ministry of Health to deal with those problems. There were changes in 2012. The responses were split in the General Healthcare Service, and we now understand it's not a good idea. We have to reconstruct a unique organization to deal, to sync, to draw the policies and to apply them in practice on the ground.
Thank you for that. I want to ask you one more question before I move on to our other panelists. Were there unintended consequences, either positive or negative, that you didn't foresee when you implemented the law?
About the law itself, probably no. I would say no unintended consequences. Some criticism that happens everywhere. We had on one way, we have activists that say, okay, using drugs is a basic human right. You should suspend any kind of sanctions, even administrative. Others say, oh, those penalties are too light you should harshen the policies, we should forbid, and this is one of the themes of the article of the Washington Post, is the position of the mayor of Porto that was vocal in defending the return to criminal sanctions to public use in certain locations. Okay, that's a kind of balance. I believe that our law is still actual, is still adequate to our reality. We have difficulties in applying and providing treatment to all those, timely treatment to all those in need for it, in providing housing and other kind of social support. But this is the way. We think that we should increase this kind of social and health responses rather than harshen the policies.
Assistant Secretary, it's nice to see you. Thank you for being here today.
Thank you.
As an individual, I appreciate your presence at this discussion today. So thank you for doing that.
Yeah, thank you. Thank you for the invitation.
So you've been at the forefront of the Biden administration in terms of some I think, really courageous policy changes that we've had here. So I want you to talk about kind of reflecting over the previous 2 years, what do you see as kind of the major accomplishments, and what do you see the 2 years ahead like? What do you hope to advance in the kind of next 2 years?
Yeah, thank you for the question, and Regina for the invitation to be here. It's definitely a pleasure to be here with my fellow panelists and everybody here as well. So we really have worked at trying to meet the moment with a range of policies to address the patterns and trends that we're seeing as it relates to substance use and overdose. And have put a number of policies in place really to try to help people increase their access, to needed services and supports. One thing that was so helpful and that we received a lot of feedback around was through the pandemic, increasing access to medication for opioid use disorder through telehealth. And then the take-home flexibilities as well. I think really help people to be able to, for one, stay safe at home, but then also continue their continuity of treatment and services. And as you know, we are working to have those flexibilities to really have them be permanent. And so that's one thing that we've been really pleased about. Also in terms of our OTPs, the regulations around sort of the use of OTPs and the medications haven't really been changed in 20 years. So we are in the process of doing some updates and some tweaks and changes there. Ultimately, same thing. The goal is to help to increase access to services and supports for people and really just to improve the care experience. So we're pleased about that. That is in process as well. But there are other things, within the next day or so, we should be releasing, hopefully soon anyway, it's close, but the updated or essentially our harm reduction framework. And Regina, I know you were a part of that when you were on the DCP, but over a year ago, we got together community providers, individuals from the harm reduction community, and ultimately, that framework can help to inform policy as it relates to harm reduction, and really helping to meet people where they're at, get them connected to needed harm reduction supports. And so we're really pleased about that as well. Ultimately, I think our work is about trying to address what we're seeing in that moment. And that's what kind of makes that second part of the question a little bit challenging. We know the sort of drug patterns and trends, they change quickly. Just maybe last month, the White House identified fentanyl and xylazine as an emerging threat. And also often the policies are geared towards addressing the things that we see in the moment. So 2 years down the line, beyond 2 years, I anticipate, it's difficult to say what things will look like, but certainly one thing we're focusing on now is working to increase access to needed care for folks, ensuring that they have the recovery supports that they need. And our recovery office is working across our centers and offices to ensure the recovery is incorporated into our programs and our grants and our services. So those are just a few areas, but a number of policies around increasing access.
You've worked at both the state and the federal level now. So you've done this work in political environments for a very long time. And maybe this is a self-interested question as someone who's kind of had very similar experiences, but I wonder if you could kind of talk about kind of the challenges or the process about kind of trying to move kind of policy in a political environment, and particularly, I think, kind of progressive policy that you think might have some backlash. So I wonder if you just want to kind of talk or reflect about kind of, how that work has been for you.
Yeah, so policy work can take time. It certainly can take time. We recently, for example, even recently, the removal of the X waiver. We know that was a real critical policy. We're still working with DEA around the training requirement and what the training will look like. And so there are often layers and stages to policy-related work that ultimately we know will make a difference in terms of the policy, but the process itself can take time. One piece I think that's really important is getting public comment. And so often we'll do that. That's, once we get the policy or the piece that we're working on to a place where it's ready for public comment, sending it out for comment is such an important piece, because often we know communities and providers who are doing the work at the community level have perhaps a different vantage point. And so sometimes we get upwards of 1,000 or more comments. And we look at those comments, we look at and we respond to the comments, and we incorporate those, as relevant and as necessary into whatever the policy document is. And that process takes time. And then once we have incorporated the comments, to then go through an additional clearance process once we get it to a place where the relevant, just important content is incorporated, and we've thought about unintended consequences and the benefits and risks, and so it is a process that takes time, but certainly one that we work at with urgency, with a real sense of urgency to be able to address what that policy is getting at. And so often we try to expedite things where we can and move things along quickly where they can, but it can be a process to ensure that there's alignment and the necessary research and stakeholder and partner engagement has happened as well.
Dr. Del Pozo, I have to call you doctor now, right? But Brandon, you have, I think, some unique experience, right? As a kind of professional and as a researcher, as a professor, you've sat at this intersection between public health and public safety for a long time. And I think, one of the lessons learned was the kind of collaborative effort between the public health and public safety folks have been kind of instrumental in the implementation and the success of the policy. So I wonder if you could kind of reflect on where do you think we are in the United States relative to that level of collaboration? Like, what have things, what have we done well? What are the opportunities? Where have we missed the mark? So I really want to have you share your, I think, kind of very unique experience here.
Yeah, thank you. So first, it's great to be here. It's great to see some of my Georgetown students here. And trillions of electrons have flown under the Atlantic Ocean in cables talking with Dr. Goulão. So it's great to see him here in person rather than on Zoom. So this is a great event. I think right now, like writ large, we're in a pretty polarized environment. And I hear public safety and public health used as cudgels against each other, right? You have people saying we need law and order, not public health, or public health people saying we need less policing. We need to, from the Floyd era of defunding police to other alternatives, we need a public health solution, not a police solution. What really struck me in researching the Portugal model, because leaving the NYPD and going to Vermont, right away, one of the first questions were, Chief, can you bring us Portugal? And I said, well, let me find out what Portugal means. And what struck me is that it doesn't use public health as a way to get policing out of the equation, but uses a public health approach to leverage existing public safety and policing systems to get the work done. And in conversations with the doctor, he's quite upfront about saying the police are out there in the community. They're collecting the folks that are engaging in the behavior we care about. Our goal is to dissuade them. And were it not for the police being out there and engaging and bringing these folks into the system, we wouldn't have what we need to get the work done. And I think that is a big takeaway from the Portuguese system. And I think another thing is that police need assurances that if they're going to be held accountable for a lot of the public order problems that problematic drug use yields, if they're going to be accountable for things like car break-ins, burglaries, public sex work, a lot of those behaviors, as well as things like domestic violence and homelessness, they need a system that not only addresses substance use disorder, but uses the approach to substance use disorder to achieve public safety outcomes as well. And I think this idea that it's one or the other, and we each have our cudgel that we hit the other one over the head with. First of all, it's a relief to be a professor and just watch that happen in the news. But as far as policy and research solutions, I think the integration that Portugal has is remarkable.
Maybe you've answered some of this already, but and I'm certainly not asking you to speak on behalf of the entirety of law enforcement and public safety. But I think, having worked in a pretty progressive state for a very long time, that was, I think, moving forward on some progressive issues. It was often law enforcement that was the pushback and the vocal opposition to what we were trying to do, despite, I think, some of the, at least public health evidence that we had at the time. And I wonder if you think one kind of like, should we be approaching public safety in a different way? And if so, like, what should that look like? So what should the collaborative efforts that Dr. Goulão put forward in terms of lessons learned look like for us here in the States?
So first, I think a lot of the resistance that policing has toward public health comes from a lot of the resistance that Americans have toward public health. When you look at the arguments that a lot of police leaders make against things like harm reduction or pick your evidence-informed intervention, they closely track a lot of the sentiments of their local electorate or a lot of the sentiments of the everyday citizen on the street. So, and then it is tinged by this traditional reliance on the idea of law and order, that like sure and swift deterrence works. But I think the heart of it, ironically, is meeting police where they're at, which is a tenet of harm reduction, right? And when I interview police officers these days for a lot of my qualitative research, they express weariness, exhaustion. A narcotics detective said, I feel like we're always 3 steps behind in our response. So I don't think they think everything is rosy. I think they want assurances that the alternatives work. And when you look at things that are getting off to fits and starts in our country, in different cities, they're looking at those instances and saying, hey, that's not working. And I think that when Regina and the doctor talk about a sustained investment in the resources that make it work, like what we have now is a lot of, like I call them boutique solutions, like a 3-year pilot program, a 1-year grant program, like a limited like duration experiment. It's hard to convince people who are dyed in the wool that those are like, you know, meaningful answers. But in Portugal, we have like well over 2 decades of if we were facing Portugal's quote unquote problems right now, we wouldn't have 106,000 overdose deaths. We might have something like 15 or 20,000 overdose deaths if we had problems on the proportion that Portugal has problems. I would take your problems any day, right? And I think we need to replicate that here in the US to start getting law enforcement to buy in.
I want you to answer the same question too. So having come from the public health side, Brandon and I were talking, there was a really interesting op-ed by Rochelle Walensky as she was leaving the CDC, talking about how like one of the lessons she learned from COVID is that those of us on the public health side can't just think of public health outcomes, right? We have to consider economic issues. We have to consider public safety and social issues. So I wonder, like, how do you kind of conceptualize your role and your work as it relates particularly to kind of engagement with a public safety community?
Yeah, such an important question. I mean, you know, one thing I so appreciate is that there are really creative collaborations and models that we're seeing across the country that are being funded in part by some of our federal resources. So whether it be block grant or SOAR, you know, in 2015, for example, Massachusetts had the Gloucester Angel program, where, you know, officers were saying, you know, we can't arrest our way out of the overdose patterns and trends that we're seeing. And ultimately had officers working to help connect individuals who were struggling to services and supports. Ultimately, that led to like a whole network of over 400 police departments across the country that were implementing similar models, similar angel programs or HOPE programs. In Connecticut, when I was commissioner, you know, there was a HOPE program that was very similar that was funded in part off of federal funds. And some of the ideas is to really meet people where they're at, and to help to connect them, you know, police departments, you know, working with sometimes community response units or other community teams, sometimes street psychiatry, to ultimately help to connect people to services and supports, or to disseminate harm reduction information or materials, or sometimes just to be there, you know, really just to be there in a compassionate way, to sort of walk alongside the person in their recovery journey. And so we've seen models like that bubbling up. But then we're also doing quite a bit of work with the Bureau of Prisons and the Chief State Justices around really working to increase access to medication-assisted treatment within prison settings. And so that is a collaboration that is currently underway. And then we're also doing quite a bit of technical assistance with states around, you know, implementing medication-assisted treatment programs within prison settings, but then also thinking about the reentry process as well. So I think there's a real role and real opportunity between sort of public health and public safety. And we're seeing some of that being implemented now through some of the harm reduction grants and other grants like programs, excuse me, like the Gloucester model.
Dr. Goulão, I want to ask you a question. You know, individuals who are engaged with the system have to go before a drug dissuasion commission, right? And are given some level of assessment and then asked in terms of getting help. Do we have any, so kind of part of my question that I'm interested in is, does it work as an intervention, right? So just as an intervention, are you seeing kind of decreases in drug use, decrease in other harmful behaviors as a result of people's intervention with the commission and then the follow-up care that they get?
Well, if you ask me with the intervention of the Commission and the follow-up, yes. Of course, there's an impact. If you ask me for the intervention of the Commission alone, the Commission is mostly a place where people have the opportunity to discuss their drug use, okay, to understand if this is a problematic use or not, and be offered the way to address and to join the adequate response. The role of the Commission may be as well the work on motivation, but not further than that. With people who are not problematic users, yes, it's very important. It acts much more as an indicate prevention tool, to understand what is going on along with drug use that may lead to more problematic use later on. Okay.
Let me ask your approach here. So, we're obviously talking about adults in the work that you're doing here. But what's your approach? What's your strategy in dealing with other populations? So, adults, women, pregnant women. So, how does your kind of strategy in Portugal kind of deal with other populations who might not necessarily have been involved with the commission? So, kind of what's your strategy in working with those?
Okay. It's important to say that decriminalization and this kind of response that operationalizes decriminalization is only one part of the system, because we have units all over the country that we call centers for integrated response, that have the responsibility to provide to the populations the activity in all the mission areas: prevention, treatment, harm reduction, reintegration. Okay? They have their own territory. They have the territorial responsibility to supply all the responses in those areas, either with their own means. Okay? Treatment mostly is supplied by the state-run units. But for instance, preventive work or harm reduction may be contractualized with NGOs by in responding to the needs identified by that unit. Okay, so I have a district to provide preventive harm reduction. I have a need. There's a significant amount of people using in a disorganized way in this place. Do I have the means to reply to that? No, I don't. So I may propose to the central authorities to launch a call for tenders for an NGO to step forward to respond to that need. Okay? The role of my agency is coordinate this kind of responses. And this is the kind of responses that lately we have had more difficulties in responding to. Okay? Not exactly by blind cuts in financing, but because it takes too long to have the authorization to spend the money that is allocated to the budget. You know well as how administration can put the foot on the accelerator or stop it as they wish. And in fact, for a given time, the administration was convinced, okay, those problems are solved, we can invest in other areas. And only when some new public manifestations of problems appear, people tend to focus and to pay attention again.
I saw you nodding when Dr. Goulão was talking about kind of consistency of funding. And I think we've all known the ups and downs of funding, and Regina talked about like not talking about a crisis mentality, because I think crisis mentality, like usually get a significant increase in funding, and then it goes away when people feel like they've kind of addressed it. And I wonder if you could kind of talk about this, like leading the witness, I know. But I wonder if you talk about, particularly at the state level, some of the challenges that you encountered in terms of this inconsistent funding, and how that really affects having kind of long-term outcomes here.
Yeah, I mean, the funding piece, it's so important. And so one thing I have to say, I so appreciate in sort of where I'm sitting now is just the level of commitment of the Biden-Harris administration for resources around sort of mental health and substance use, and Congress as well. I mean, we've seen significant increases in our budget all around. And so I think that has really helped in terms of funding states and states that are working with communities and their partners. And so I think that certainly has been a real value in terms of addressing the challenges that we're seeing. Consistency is often a challenge. We often will work with our grantees around sort of thinking about sustainability, thinking about ways to continue, different programs, perhaps beyond, beyond the resources. And so that's an ongoing challenge area. I think it's an ongoing area of discussion. I've seen states do real creative work with incorporating certain programs or certain services into their Medicaid plans or some of their demonstrations. And so there's always opportunity there. But the funding piece and thinking sort of long-term and in terms of consistency is an important area, certainly one that we're looking at and having conversations about as well.
Thank you. One of the things that you identified was the lack of consistent funding, right? To give people the resources that they need once they're identified here as a major source of kind of problems here. So how did that change? Did you have changes in administration? Did people acknowledge that you needed additional resources to be able to address the issues? How did you get kind of a reinvigoration of funding to support the work that needed to happen?
For a while, drug-related problems became like invisible in our society. We had installed a set of responses to deal with drug-related problems. And at a given period, by 2009, the government thought those responses were oversized. Hopefully, instead of decreasing the resources and the number of professionals, the government included new problems in the mandate of the services. First step in 2009 was to include alcohol-related problems in the mandate of the Institute. And later on, in 2012, it included another government, included in the mandate of CICAD, my service, as a strange name, Service for the Intervention on Addictive Behaviors and Dependencies, including gambling, gaming, screen dependence. So nowadays we have a mandate for all that. But when, as a consequence of the pandemic or related to the pandemic, we had a new pushback in drug-related problems, suddenly we had too much to deal with, okay? And difficulties increased. So we did not used to have waiting lists for treatment. Nowadays we have. I have to admit we have those, and people more visible, more disorganized is again on the street. For a while, we did not have this kind of problems. And once again, and coming back to the famous article, this is true that we have difficulties nowadays. So we have to relaunch and to reinvest more seriously in the responses, timely responses to the people that are more disorganized nowadays.
Brandon, I understand you're about to launch a study in Portugal. I wonder if you could talk about what the focus of your research is going to be.
Yeah, no, thanks. So we're pretty far along in organizing and launching that study, and it's mostly funded. So
Are you making a plea?
I'm making some eye contact in the audience. No, it's to launch a study in another country, surprisingly complicated. But the point is this, right? That there's a lot of opinions in American policing about what decriminalization looks like. There are American police executives who are looking at decriminalization in their own backyard and opining on it. There's thoughts about what Portugal must or must not mean from the perspective of American police. To our knowledge, in the English language, no one has ever just asked the Portuguese police over the last 20-something years what they've made of working in this environment, what their role is, whether it's acceptable or feasible to them. And so we want to ask what seems like a super obvious question, but it's surprisingly novel, which is go to Portugal and ask the Portuguese police what they think of Portuguese drug decriminalization. And maybe that'll provide some useful context for US police. I have this vision of I'm giving away my lead or my opening slide at the conference in 2 years from now, but I have this vision of Portuguese and US police from the bicep down. Not, you can't see the face or the patch, and you can't tell the difference. That could be New York, it could be DC. They look like the police. And I want to know what those men and women make of working in Dr. Goulau's regime.
Let me ask a final question, and then we'll start taking questions from the audience. We've often talked about the role, and the longer I do this work, the more I'm convinced of the kind of destructive forces of stigma that play in terms of people's inability. One of the things, the manifestations, is prohibiting people from getting care, and I wonder if you have any thoughts in terms of the effect that the law had around kind of stigma that people particularly felt on the individual level in terms of asking help, or in terms of the general public. Did it change people's attitudes about kind of people with substance use issues?
I think that the decrease of stigma of people who use drugs is one of the main impacts of our policy. In fact, there's a respectful attitude towards users, and it is related to the idea that we assume that it's better to approach those problems from a health point of view. Okay. Better treat than punish is the phrase that relates this attitude. Don't forget, once again, we were coming out of a dictatorship when people tended not to assume their need of help, fearing to be referred to the police or to the police authorities. So decriminalization took this out of equation as well. So there were elderly drug users tended to fear to approach the system because, okay, I may end up in prison because someone is going to, this doctor is going to call the police so it's a long way from that, but I believe that it had a very positive impact in stigma and self-discrimination as well.
I'm going to ask one more question. So, Miriam, you're in charge of both mental health issues and substance use issues, probably two of the most highly stigmatized diseases in the world. So, give me your assessment of where you think we are right now in terms of kind of stigma. I'm thinking particularly not on the kind of policy and kind of legal, but more on the individual level. Like, where have we made progress and where do we need to go?
Yeah, I mean, I think, I actually think because of the pandemic, we have perhaps made some progress. It feels like we're having more conversations about mental health and the challenges that people may be experiencing. We have more people coming out sharing some of their mental health or substance use related challenges, whether it be individuals in sports or in actors and actresses. And so I think there are more conversations that seem to be happening. At the same time, though, I think there still is stigma, quite a bit of stigma that we're seeing as it relates to, for example, even medication-assisted treatment. So we know that there is work to do in terms of addressing stigma and really helping mental health to be, as we talk about physical health, we see mental health is right along those lines. And so really want to reduce the barriers that people feel in terms of having conversations, in terms of being open, in terms of just their own experiences. And we know we have work to do there. One resource I do want to share is our Talk They Hear You app, because we know we sometimes hear that even parents are having a difficult time. Like, how do we even bring up conversations with young people and others? So we do have an app called Talk They Hear You that is downloadable, and it has conversation starters that can be used to start conversations around substance use or mental health with young folks, and can be a real valuable resource, as well as vignettes and just a lot of rich information around sort of starting conversations related to mental health or substance use related challenges. So
I think we're gonna take
So we have several folks have submitted questions on Zoom. If you in the audience here have questions, if you could write them out and give them to our incredible staff, who I want to thank them for all the work that they did to put this together for several months now. It seems seamless, but it took a lot of people to do great work. So questions you can hand to staff who are on the side.
And thank you for the incredibly neat handwriting, so I can read these. So the question is, please describe the treatment of opioid use disorder in Portugal in terms of the availability of buprenorphine and methadone. Is there low threshold treatment available?
Okay, thank you. We have the kind of the entrance point for the system of treatment is mostly voluntary. People knock the door to treatment centers. I would say that the dissuasion system is only a complementary gateway for the system. Okay? So most of the people that seek for treatment address treatment centers. As I said, the centers for integrated responses, one on each district at least, and they just knock the door. The entrance point stands on an evaluation by a professional of mental health, psychiatrist, psychologist, whatever, along with the evaluation of a social worker that prepares from the beginning planning of the reintegration process. Okay? And there's the kind of treatment that someone with opioids disorder depends on the conditions, either to make an inpatient detoxification, it's called, followed by psychological support, long-standing, eventually with a stay in a therapeutic community to regain other kind of skills, or it can focus, the choice may be only to choose the use of an opioid therapy with methadone or buprenorphine. In a high threshold in a treatment environment, the rules are quite far more demanding in terms of abstinence of opioids or other substances such as cocaine. But if the person is not able to comply with those rules, he may be passed to low threshold programs in the environment of harm reduction, mostly with methadone. We do not use buprenorphine in low threshold programs. Methadone is provided by the state for free, and we have distribution in big cities by vans that circulate and stop at a given places at given hours. To give you an idea, in Lisbon alone, we have 1,600 people in low threshold methadone programs every day, 24. So this is mostly the kind of offer. Buprenorphine not available in low threshold programs because methadone is provided for free. Buprenorphine has to be bought at pharmacists. So we do not use in those low threshold programs.
One of the questions that someone asked is, what happens when someone doesn't show up to the dissuasion panel? What are the consequences? Are there consequences? What's the
There are consequences because the intimation of the police authority to present at the dissuasion commission is an administrative order, and the disobedience may be pursued as a crime of disobedience, not for using illicit substances, but for disobeying to the order. So the people may be charged for it. But I must say that most of the people that are intimated to present to the commissions, more than 85% present at the first call. If they don't, the police may insist in intimating them, and the compliance arises still more. Yes.
One of the questions that we had, and I'm going to ask Miriam to respond to this too, because I know this is an issue, dramatic issue here in the United States. Kind of with the increase in treatment demand in Portugal as a result of this, did you have a behavioral health workforce shortage? And how did you address it? And Miriam, you can kind of dovetail on that and say, like, with kind of increase in money, focus, attention, what are we seeing here? But I'll ask you to respond. Did you have a workforce shortage, and how did you kind of address that?
Yes, we had a shortage related to the increased needs, and what we are working on that. We did not manage to increase the workforce as needed, but public institute addressing those addiction issues in general is going to be recreated and come into force on 1st of January next year. So we are working nowadays in preparing new recruitments, new tools to increase the capacity for treatment in the other mission areas.
You want to talk about what we're seeing here?
Yeah. So we definitely are seeing workforce shortages and challenges as well. I mean, PERSA recently put out a report that by 2025, we could be as much as 31,000 FTEs short of behavioral health providers. So it's definitely something that we're looking at, that we're paying attention to. It is one of our key priority areas now within our strategic plan. So that's something that we're really in a targeted, focused way looking at, as is HHS, or also as an HHS workforce plan as well. HRSA does quite a bit of work here in terms of funding different either physician positions or behavioral health positions. We have a bit of work going on here as well in terms of, for example, recently we were so pleased to be able to release our peer recovery standards, model standards. I think those are certification standards, and that can help with really working to expand the peer recovery workforce. But then we also have programs like the Minority Fellowship Program that will fund positions across psychology, psychiatry, marriage and family therapy, addiction counseling. And so that ultimately is working to increasing the numbers of individuals, within the behavioral health professions. And then we do quite a bit of training in technical systems, because I think a part of the workforce challenge that is really important is maintaining the existing workforce. So we know providing training and technical assistance such that the existing workforce is strong and able to meet the challenges that we're seeing across the board in terms of, across behavioral health, really. So we have a number of technical assistance centers across prevention, treatment, recovery, and then some targeted centers of excellence, looking at different demographic groups. So an African-American Center of Excellence, Latino, Tribal Center of Excellence. And so that's really geared towards strengthening and training the existing workforce. So those are just a few of our programs. We have others where we work with HBCUs and soon HSUs to ultimately attract folks to the behavioral health professions. We know that's an important piece as well. So folks that are maybe in college, thinking about what they want to major in, and working to bring them to and expose them to the behavioral health professions. So just a few areas of our work.
Brandon, a question, and again, not asking you to kind of represent the entirety of law enforcement, but I think it's a really valid question. So given the history of US policing, and particularly its use of excessive force against people of color and people in crisis, so what do you think we can do? What can we put in place here to ensure that actually drug users who are intersecting with law enforcement actually get referred to care in an equitable way?
I'm going to take you asking that question to take one liberty, which is a buried lead in Dr. Goulau's response is free, low threshold mobile methadone. Let that sink in for a second. Free, low threshold mobile methadone. I just want that on the record. No, right. That's one of the biggest, there's a big trust gap between people who use drugs and the police, people of color and the police. And it's not two circles in a Venn diagram, it's three, right? Race, the stigma of drug use, and the history of inequitable policing. So there's not, an easy overnight answer to that. But one of the things that police can do to regain or maintain or enhance trust is to put institutions to put their money where their mouth is about genuine referral to care in lieu of arrest and charges, in lieu of use of force or punitive outcomes. It might take years of doing that in good faith to bring people around. For the record, I've been out of policing completely for 3.5 years, and police would shudder to think that I'm speaking on their behalf. So I'm not. But I will say that there also needs to be people who use drugs involved in the planning of these processes, right? It's not just the police like very imperiously roll out, here is our diversion program that we will bestow upon you. It has to be, we are talking with the people that we normally arrest for the petty theft and the drug use and the outdoor sex work. We're going to work with them and providers to develop feasible, acceptable, effective programs where we as police are one of the actors that develop this in conjunction with the other stakeholders. That's a critical step. And it's not just about people who use drugs, but of course, communities of color.
Thank you. I think this is a timely question. It's a little bit off topic, but I want to take it anyway. So someone asked a question about, DC stands on the district stands on the verge of getting a significant amount of opioid settlement money. And I know we've had O'Neill and others have put out guidance in terms of, how do you think about both the process and the application of these opiate settlement dollars in the most effective way. So I wonder if you have any kind of thoughts here or kind of guidance as states, municipalities, jurisdictions think about the investment that they can make to make the most impact.
Yeah, such an important question. I mean, I think, important thing is really for the state or the municipality to really look at their programs and to try to get a sense of are there particular gaps. So if they do mapping around sort of what is available, are there gaps based on other areas of work that could be supported? In addition to that, I mean, we will often work with and have work with states and sent states letters around ways to use some of the resources that we disseminate. And so a lot of that truly could be generalized as well to opioid related resources or to settlement related dollars. So we'll sometimes, put letters together where we put together ideas based on what we're seeing. So sort of sharing of ideas. We'll see certain states implementing programs and then we'll, just include that in just a memo so that others are aware of just a range of really creative work that's happening. All of that could be generalized to the use in terms of the settlement dollars as well. But the main thing I would say it's important to take a look at what's available. I mean, I love doing, in a previous life, love doing sort of resource or asset mapping. So you can look at hotspot areas and then based on the hotspots in terms of where there are either overdose trends or where there are high need areas, and then look at where are the resources as it relates to those areas. And so it may identify different gaps or needs that could be funded through the settlement resources. I will mention one other thing that we've seen really across the country, and our federal dollars are funding these, and it certainly, if there are additional resources folks have, whether it's settlement or other, the mobile means are just a great way to get resources out to communities. We know that some community groups or individuals, if they're not ready yet to access services, but if they're able to engage with somebody through a mobile means or engage with an individual recovery or an outreach worker, that can help with an individual ultimately accessing services and supports. So mobile means have just been a wonderful model. We've seen RVs, like really creative RVs that do induction, that do harm reduction dissemination. And so it's been wonderful just to see that expand across the country.
Thank you. Dr. Goulão, a question, which is also, I think, part of SAMHSA's kind of strategy here too, is, can you expand on the social services? So beyond just kind of treatment, what are services that are available for people who need, for instance, employment assistance, housing assistance? Are there other social services that are available for people who need that kind of help?
Yes, on top of the official services that deal with those particular teams, housing, employment, and so on, there are NGOs that work related with us, with the official responses, in order to facilitate the access to assist the client, I would say, to assess and to move through the system. There's a kind of someone in charge of guiding the client to move and to assess the different responses where they exist. Okay, so that's there are no specific responses for this, but moving through the system for the client himself would be very, very difficult and very, so there are the most important role of professionals that work with us is to guide and to assess and to.
So there's some case management services.
Yes,
that's great. Good. Miriam, I know kind of recovery support services is a kind of big part of the growing SAMHSA portfolio. Wonder you want to kind of talk about kind of what's been happening and where we're going here.
Yeah. So we've been thrilled to be able to launch our Office of Recovery. We announced last September that the office was fully staffed, and so now we've been working to, as I mentioned, we recently released the model standards for peer certification, and so that was an initial product that the office put out recently. But we've also been really incorporating sort of recovery language in all of our notice of funding opportunities. So this has been a real, I think, important way to break down silos. And so we will encourage across our grants that recovery support services or recovery support specialists are incorporated into the grant. And so I think that provides a real opportunity for thinking about whatever the grant is, but also thinking about some of those wraparound supports as well. So we're really excited about that work. And then the office is working across the centers. Like recovery is now one of our cross-cutting principles. So we have the office, but we really see it as just such a critical cross-cutting principle that ultimately undergirds all of our work. And so the office, they've been quite busy as a team, really connecting with each of our centers. So whether it be the Center for Substance Abuse Prevention, Substance Abuse Treatment, our Center for Mental Health Services, as well as our offices, because we see that there's just an important intersection there. So quite a bit of work going on. They're doing a lot of roundtables. Like we think it's so important to listen. We really believe in that mantra that people remind us, look, nothing about us without us. Nothing about us without us. And so we often will do roundtables or listening sessions with individuals in recovery or visit programs. I think that's really been helpful to visit some of the recovery community centers and other sites to see some of the work that's going on, because that really then can help to fuel some of our thinking in terms of grants and programs that we're implementing. In fact, I have a coffee hour later this afternoon, and many of the recovery community organizations and recovery groups will be part of that as well. So, so quite a bit of work happening, but really thinking about recovery from a cross-cutting perspective and how it's part of all of what we do at SAMHSA, not necessarily just a standalone office. And so that's been really exciting.
I think this concept of involving people with lived experience, people are still using, people are in recovery, is, I think has to be a basic and institutionalized component of what we do. They're the folks who can tell us what they need and what they want to be able to do. Since you made an editorial comment, I'm going to make my one editorial comment that I hate the expression low threshold treatment, but I think we should just call it treatment. Because I think it distinguishes one from the other, and I think it's really idiotic. We don't call low threshold diabetes care different from diabetes care. We just call it diabetes care. So anyway, that's my editorial comments.
Noted.
I wasn't saying that directed toward you. But that's the. So we have 5 minutes left. I want to ask this question because it's, I think, a growing issue here in the United States. Certainly, it's been an issue on both the mental health and the addiction side here, and that's this concept of involuntary treatment, right? And so I think people have, there's this notion that kind of going in front of the commission is kind of mandated treatment or involuntary treatment. And I wonder if you could kind of speak to that and kind of what's people's experience like? Do they see this as kind of involuntary treatment or mandated treatment?
In the commission, there's no voluntary or involuntary treatment. There's a place, a moment to discuss with health professionals the kind of use that you have. But from that, there's no mandatory decisions. Okay. Let's assume I am a problematic user. The commission will invite you to join a treatment facility, but you are free to refuse. Okay, it's not mandatory. Okay, what will the commission tell you by the end of this interview? Okay, please do not come here again in the next, let's say, 6 months. For the same reason, by being intercepted by the police, using drugs or in possession of drugs. If you wish to initiate a treatment process or whatever, come here. We'll assist you in finding a gateway to it. So this is not a mandatory treatment. It's a moment to reflect, to assume, and to understand what kind of role do drugs play in your life. So and that's the main result of this interview, or this interaction.
Just in the remaining time we have left, I want to ask each of our panelists for some kind of closing comments here. So you've been very gracious with your time here in the United States. You've had countless delegations come to Portugal to look at it. So in terms of like, what advice do you have for the United States in terms of moving forward here? Just in broad general drug policy terms, what do you want to make sure that we pay attention to, or that we consider as we continue to make changes to drug policy here in the United States?
You know, what I feel, and I had several interactions with American authorities in different states, in different moments. What I feel is that we have different mindsets as well that are caused by two main aspects. For one side, the organization of the health system in the States, okay? We have a universal health system for free for citizens. We pay it with our taxes, but in our logics, we do not have to think about insurances, who pay, who supports, who is going to support this or that supply. Okay. So in my view, it's much easier to think about, because things are there. That's a decision about where to allocate resources or not. The resources are already available for that distribution. So in terms of organization, is that one. On the other side, I think you are living a momentum that is quite similar to what we had in the 90s concerning the heroin use. It was attaining all Portuguese families. Okay? We had a true epidemic related to heroin who was devastating our society. And that was the moment to develop humane policies. When the problems are mostly in marginalized communities, nobody cares. When it's my children who is affected, things are different. It happened with the medium class, upper class, it's political class, everybody. I think your opioid epidemic here in the States and in Canada is a momentum to rethink those policies, is a kind of a window of opportunity to open minds to new solutions. This is what I feel in all this. There are some practical differences, difficulties, but we are in different steps in legalizing cannabis, for instance. You did it, or most of the states are doing it. We did not do it yet. But meanwhile, decriminalizing the use of heavy substance would be a very important step to develop further all the policies. I think I would seriously advise that it would be a very good step for states to do.
Miriam, I want to ask you kind of, we've been trying to pivot for a very long time to thinking about substance use issues to a public health and a health related issue. Without, you don't have to get into specifics, but where do you think we are in that journey? What work remains to be done, and like how do you think we get there ultimately?
Yeah, I mean, there is definitely more work to be done. I think when we look at our overdose numbers and just look at the patterns and trends that we're seeing across the country there, we know that there's more work to be done. I mean, we about 2 years ago implemented the Secretary's overdose prevention strategy. And so it does mention and sort of outline 4 pillars of really critical areas of work where we're focused. So really thinking about evidence-based treatment, we know that that is so critical. Working to ensure that there is access to evidence-based treatment. Thinking about primary prevention. We know primary prevention is really key as well. What can we do within school settings, within other places to address prevention upstream? And so that is a critical area as well. We know recovery supports are also important, and that's a real one of the key pillars of the overdose prevention strategy. But then also harm reduction. We know harm reduction work is really vital in terms of meeting people where they're at, and connecting them with resources, with supports, with harm reduction information. All of that, I think, in combination makes a difference. And then for us, I think really our key partnerships, just partnerships with our grantees across the country that are doing really, really vital work with the resources that we've been allocated. And again, we've seen increases in SOAR. Our SOAR grant funds a broad range of prevention, treatment, recovery related work. And the states are just all leaned and dialed in there and doing really creative work to address some of the patterns and trends. But we know we have more work to do. And so I think that's where many of us are focused.
Brendan, final thoughts, comments here?
I think that we could all benefit from number one, getting away from the heated rhetoric, number one, and number two, with some humility. Like, America is so tempting because we have all the extremes here. And so some folks will look at the most beset neighborhoods in Philadelphia or San Francisco and say, look, that's proof that harm reduction doesn't work and we have to stop. Then on the other side, we'll look at charging the lone teenage survivor of a triple overdose with homicide because she shared the drugs with her friends before they died on the eve of their high school graduation, and say, look at that homicide charge and go, police should have no role in overdose. Look what they do. That's barbaric, right? And then we have, like, quietly across the Atlantic, a country that's like taken aspects of public safety and policing and taking aspects of public health and married them. And in their context, which is not the US context, but is not entirely irrelevant, they've been largely successful for 23 years, more or less. And I guess what's been a relief for me leaving policing and going into research is I think you can't, at least in the beginning of your research, maybe the end of your research career, you can be arrogant, but in the beginning, you have to have some humility. And it's been really interesting to abandon those polarizations and look at a place like Portugal and start teasing it apart and say, like, what's working here and what can we import? And I think as long as we allow ourselves to fall under the narratives of, like, the most beset neighborhoods or drug-induced homicide and use them to polarize ourselves against each other, like, we're missing, in the spirit of humility, a lot of really important evidence-informed lessons. And Portugal can offer some of those.
Thank you. I think that's a beautiful way to end the panel today, with a principle of recovery, which is humility, which I think is great. I want to thank all of our panelists today. I want to thank O'Neill and T4 so thank you, everybody.